Hello, and welcome everyone to the second of our two-part Heal Connections learning and sharing session today on inclusive language, imagery, and storytelling for addiction and pain teams. Today, we are going to focus on the specific needs of pain research teams. We are going to be led today by our fearless moderator, Dr. Burl Gooden, who is a key collaborator in Heal Connections and a pain research expert. He's going to introduce our agenda today and tell you more about the speakers you will be hearing from. We will be going through and leaving plenty of time for chat, but as you hear things that interest you, feel free to go into the chat and leave questions and comments so that they're all ready at the end of this. Burl, over 300 folks have registered today, which I think speaks to how important this topic is. So Burl, thank you so much for your vision and insight in helping us shape this important sharing session today. Take it away.
Well, you give me way too much credit, but I appreciate that. And I'm very happy to be a part of this very important effort here. I see the folks coming through in terms of the growing number of participants on this webinar right now, and that's very encouraging to see. And the assumption here, which I believe to be a truth, is that everybody cares about this topic and how it is relevant for them in their research, lived experiences, people that they interact with. And what we're talking about here is stigma. We'll be hearing a lot more about that as a social determinant of health in the coming hour-ish. But for the agenda today, momentarily, I'll introduce all of our amazing panelists. And we will then hear from Dr. Janelle Letson, who's going to talk about perspectives of those with lived experiences dealing with pain, both acute and chronic, particularly that chronic type. We'll hear some flash talks on pain, stigma, how it affects individuals, and then also what might be done about it. Once the panelists have kind of gone through their respective content, we'll have some opportunities for question and answers on this topic. And then you can see there toward the end, we'll have some closing remarks, reminders, some housekeeping about upcoming future programming that folks might be interested in. And then we'll try to round that out at around the 2:30 mark if you're on the East Coast, or for me here centrally around 1:30. But again, my name is Burl Gooden. I'm a professor of anesthesiology at Washington University in St. Louis. And things related to pain and stigma are something that I'm very interested in. Now I'm going to introduce the panelists. First and foremost, we have Dr. Janelle Letson, who is affiliated with the National Institutes of Health, particularly the National Institute of Neurological Disorders and Stroke, in their Office of Pain Policy and Planning. We have Dr. Carrie Cavanaugh, who's a physician scientist and associate professor, trained as a nephrologist at Vanderbilt University. So we'll have an interesting perspective from our physician colleague. We have soon-to-be Dr. Joanna Hobson, who is a PhD candidate in the behavioral neuroscience program at the University of Alabama, Birmingham. I work closely with Joanna. She's a lovely individual. We have Kate Nicholson, who is actually a civil rights attorney and the CEO of the National Pain Advocacy Center. And she is an expert as it pertains to the Americans with Disabilities Act. So there's another intriguing perspective on things. We have Dr. Simitri Sill, who's an associate professor and pediatric psychologist down in Atlanta at Emory University and Children's of Atlanta. Fun fact, Simitri Sill and I went to graduate school together at the University of Maryland, Baltimore County. Go Retrievers. And then last but not least, we have Dr. Emily Wakefield, who is an assistant professor at the University of Connecticut School of Medicine and is also affiliated with Connecticut Children's. Dr. Wakefield is also a pediatric psychologist who does a lot of work in this pain stigma space, and she and I are actively collaborating on some work, so that's fun to do things with your friends. All right, so there's our basic introductions, and then ultimately our learning objectives for today. What we hope folks will take away when we're done here is some real-world examples for how best to communicate in this space with respect to your community partners, stakeholders, bit of an antiquated term, but your community partners, your partners in crime here, maybe that's not the best term either. I'll stick to the script. For those living with pain stigma, and then the research perspective in terms of how it's influencing and impacting people with lived experience. Also, we'll, and this is perhaps for something that's of great interest, is actionable resources to engage people with lived experience while reducing stigma and make research communications more engaging and influential. And then hear about opportunities to partner with Heal Connections to support the use of inclusive language, imagery, and communications in your product development in terms of things that you're trying to disseminate and otherwise get out to the populations that are most of interest to you. And then forthcoming, there will be a little bit more information about what Heal Connections is. It's basically meant to be a conduit for research, dissemination, and engagement. I'm a co-investigator there, so I have a little bit more information as people are interested in that. So without further ado, let me bring it to my friend and colleague, Dr. Janelle Letson, who's going to talk to us about the importance of including people with lived experience in pain research. Dr. Letson, my friend.
Great, thank you so much, Pearl. So I am truly honored to help open today's session, which, as Pearl alluded to, includes a really fantastic lineup of experts in inclusive language, imagery, and storytelling for pain research. And all of these goals can be supported and strengthened by engaging people with lived experience of pain in the research process. So I'll talk a little bit about that today. The experience of pain itself is a subjective one. And so this means that only the person who's living with pain can truly know what their pain feels like. And because it's subjective, it's often considered an invisible condition. Unfortunately, what happens sometimes more often than not is that when people aren't fully believed in their self-report of their pain experience, then they might have invalidation of that experience, and in some cases, stigma, which today's speakers will describe more deeply. It's also important to note that because of implicit and explicit biases, this invalidation and stigma are often compounded for people who hold marginalized identities. Throughout some of the talks in today's session, you'll hear the term people with lived experience of pain. And this usually refers to someone who lives directly with pain, but it can also refer to their caregivers or even to leaders who are advocates for their communities. And those are people who have intimate knowledge, either first or secondhand, of their community's unmet needs, their cultural values, and their preferences. And we think about people with lived experience as experience experts. And what that means is that they have expertise in what it's like to get through life's daily activities while you're carrying that additional burden of pain, what it's like to navigate the healthcare system with an invisible condition, and how pain can impact a person's quality of life and well-being. When we engage people with lived experience who come from populations that are marginalized in pain research, then we can improve health equity in pain care because we include those voices that have been historically excluded from our work. And so for all of these reasons, engagement of people with lived experience of pain, which I'm also sometimes going to refer to as patient and community engagement, this is really a core value of HEAL research. And as a core value, we have many different ongoing efforts within NIH to help promote and support patient and community engagement in HEAL research. So this slide just shows some of the people and groups at NIH who are involved in these efforts. And one group in particular that I wanted to just draw your attention to is in the top right corner, the HEAL Community Partners Committee. And this is a group of 11 people with lived experience of pain and or opioid use disorder who have really been thought leaders in how the HEAL initiative is approaching patient and community engagement in research. So a lot of what I'll share in these next few slides has been co-produced with this committee, and I really just want to acknowledge how grateful we are for their partnership in these efforts. Patient and community engagement in HEAL research refers to effectively involving people with lived experience of pain and or opioid use disorder throughout the research process, and doing this in a way so that findings can be useful for real people in real communities. So primarily, this means engaging people who directly experience pain, their caregivers or community leaders, so those people with lived experience of pain, But this can also include other relevant collaborators who would provide a unique perspective. So this might be healthcare providers or policymakers, people in the legal system, are just a few examples. And when we think about when you can engage people with lived experience of pain, it can really be at any point in a research project's life cycle. So a lot of times where it happens is in those kind of like guiding recruitment and retention efforts, or some investigators might think that kind of just having research participants who have pain might be engagement. But really it's those decision points in the research project is where we think about engagement occurring. And the sooner that people are engaged, the better for the research project. So on this slide are just some of those key decision points in a research project's life cycle. So starting from when you think about what the main question of the research project will try to answer, how the methods and plan and study will be designed, how to recruit and retain participants to promote diversity, equity, and inclusion, how to monitor the research project to make sure that you're looking for any safety or ethical concerns, analyzing the data and interpreting the findings to conclude things about what your study had found, and then importantly, making sure that the study findings are disseminated back out to the scientific community, and then where as researchers sometimes is less thought about is to the general public, back out to the research participants, and back out to communities who are directly affected by what the research project was studying in the first place. And so if you include people with lived experience of pain in these time points, then they can have important perspectives that can just enrich the work. So just a couple of examples here. For example, in that first step of engaging people in developing the study question, it can make sure that the question is meaningful to those communities and also relevant to those communities. Another place is in how the proposed methods are being designed and put forward. People with lived experience of pain can give you a lot of insights about how to minimize burden so that your research participants will be able to go through the study, will be able to stay in the study, and will actually want to participate in the study. And it will also provide some information about what kind of accommodations might be needed to make the experience as comfortable and safe as possible. At the heart of HEAL research is really finding ways to improve the quality of life, well-being, and safety of people who have lived experiences of pain and/or opioid use disorder. And we think about engagement of people with lived experience of pain and/or opioid use disorder in our research as ways of helping to advance this goal. And it does so by improving the precision of science, by improving the meaningfulness of findings for people within those affected communities, by improving the likelihood that communities will have knowledge of research findings, which doesn't always happen if it just goes into a scientific journal and that's where the findings end. And then if they have knowledge, then they can actually benefit from those findings. And of course, improving health equity and reducing stigma. So I'll just close out this intro by saying that an important thing to keep in mind is to authentically engage people with lived experience in your work. And so this means to value their experience as an important form of expertise in the research planning process, and making sure that those people feel like their perspectives and suggestions are taken seriously and not just kind of a little checkbox. That's one of the things that you have to do as a researcher. And so to do this kind of engagement effectively, it requires an open dialogue between the researchers and those community partners or people with lived experience. It is doing it in a way that shares power. And so what that can look like is offering shared authorship on scientific papers, or the chance to co-present your research with those people with lived experience who were your project's advisors. It does so in a way also that's collaborative and benefits both the research team and the people with lived experience in their community, so not just the researchers. It does so in a way that avoids tokenism. And this is something that the HEAL Community Partner Committee has really emphasized to us at NIH, is to have this kind of engagement be done in a way that is authentic and not just that checkbox approach. And finally, done in a way that aligns with community needs, cultural values, and preferences for how those people would want to offer their feedback. And so on the right side of the screen here is a QR code that you'll see. And if you follow that QR code or the link that's in the chat, it will just take you to a web page that's kind of a living web page that we have right now, where we have some resources that are currently available for patient and community engagement in HEAL research. It is, like I said, a living document. So if you check back over the next coming weeks and months, we hope to be updating this with more resources regularly. And so with that, I'm going to pass it back to Dr. Burl Gooden, who will introduce today's talks. And I will just say that I've had a sneak peek at their slides and know that everyone in the audience is in for a real treat. And so thank you all so much for your attention and for this opportunity. I appreciate it.
Awesome. Dr. Letson, that was an amazing introduction to kick things off. So I've already introduced our panelists, but just to orient folks to the order of what's going to be happening next, as soon as I finish up here, our friend Kate is going to provide some foundational information related to the phenomenon that is pain stigma. And then Joanna is going to talk about some research showing how stigma and discrimination link up with important chronic pain-related variables and factors. And that's some research that's near and dear to my heart because Joanna and I work together. Then it'll be Emily, who's going to talk about a different perspective as it relates to pain stigma, and that's going to be kids and their experiences of chronic pain and the stigma they're in. And then from there, it'll segue to Symmetry. And in that same vein, it'll be children, but children specifically with sickle cell disease. So there's another interesting twist to disease sort of related stigma in the context of also experiencing chronic pain. And then we'll round that out with some action items to mitigate and ideally eliminate stigma that will be discussed by Carrie Kavanaugh, our physician scientist collaborator here. And then when we're done with that, we'll go over to the question and answer type stuff. But without further ado, Kate, my friend, let it rip.
Thank you, Burl. Hi, I'm really honored to be here today to talk about pain stigma. So pain stigma arises from a lot of different sources, including ancient ideas that still resonate today. This is a photograph of Aristotle, who believed that pain was related to evil, and so it was preordained and deserved. And that's reflected also in the Latin word for pain, which means punishment or penalty. And it's not just in Western traditions that these stigmas exist. Melanie Thernstrom has written a book that really surveys how pain stigmas exist throughout global culture. So in the modern world, the invisible and subjective nature of pain can often frustrate the core way of knowing in medicine, which focuses on identifying pathology. And that opens the doors to ideas of malingering or faking it to get something. One of our advisors at NPAC has written about the history of pain without lesion in regard to pain stigma. And he wrote about all of these railroad accidents that happened in the 19th century, where people got really badly injured and they needed to recover for costs from the railroad, but often didn't have an objective source that they could show for the pain. So this idea that they were just trying to get money from the railway came about. And the idea that people with pain are takers and fakers exists today in views that people may be trying to get benefits or workers' compensation or recover for lawsuits or also be seeking drugs. Another thing that I think is nice to remember is Susan Sontag's idea that in diseases that are poorly understood in their time, like chronic pain, the lack of understanding or ambiguity is usually resolved against those who suffer through the use of stigmatizing metaphors. So stigma is intimately connected to power. It is structural. Obviously, there is a hierarchy within the clinical relationship between the patient and provider, but at the social level, disadvantaged groups are far more likely to suffer from stigma. And this opens the door to another related concept, and that is bias and injustice. We know that there are really well-established racial biases in regard to pain, both in terms of how providers rate the pain of Black and Brown persons, and in terms of how much medication people receive. And this owes to the history of race medicine and how we have promulgated and waged our drug policy in the United States in particular. There's also bias that women experience, who may be more often dismissed or disbelieved in their pain, which owes to a history of hysteria. And this is really just the tip of the iceberg. It happens on the basis of many identities. And the sad truth is that at a population level, these groups are likely to experience more pain. So this opens the door to injustice, the idea of being disbelieved or dismissed based on your identity. And in this case, it's revealing the most intimate details of your health and body. Another really important concept when we're thinking about stigma is intersectionality, because people don't come as Black or female or disabled. We often exist at the intersection of many identities. Kimberly Crenshaw had an insight that where the identities intersect, disadvantages tend to compound. But she also had an insight that I think is really important for pain. And that is that people at the intersections are also made invisible, and people with pain are already experiencing an invisible condition and being dismissed. And she made the point that when we focus on a big category like race, we'll often mythologize a universal experience. And she's explained this really well in a 2016 TED Talk, where she asked everyone in the audience to stand up and to start sitting down when they heard the name of someone they recognized. And she began to name Black men who had died in encounters with police, and about half of the audience sat down. And then she asked everyone to stand and began to list Black women's names. And almost everyone remained standing. Now, this was before Breonna Taylor, but the point is that these women didn't fit into our preconceptions or stereotypes, so their experience was made invalid and disappeared. And this can happen even in research. We know, for example, that pain disparately affects older people. There are well-established racial biases, yet there's a dearth of research on pain in aging Black men because they don't fit into our preconceptions. So I want to have a real pain story. This is a woman in my group. Her name is Kiana Madison. She underwent preventive surgeries for cancer and suffered significant post-surgical complications, including a vaginal cuff tear that nearly cost her life. And even when those healed, she had persistent post-surgical pain. And so once went into the emergency room at a loss for why she was experiencing so much pain. And simply asked the nurse who was drawing her blood to use a smaller gauge needle because she explained that she was weirdly hypersensitive to all pain. But the nurse assumed that she was seeking drugs and actually called the police on her. So I just want to echo why people with lived experience should be included in research, since I am the person with lived experience of pain on this panel. There are moral and political reasons for inclusion that are encapsulated in a phrase, "nothing about us without us," which was a clarion call of the disability rights movement. But it just translates to the idea that people who are most affected by the outcomes of research and policy should have some input in them. There are also practical reasons. People with lived experience may have a perspective on their disease you haven't considered. And an example that sort of takes these and puts them together, there's a lot of literature that shows that people with disabilities rate their quality of life very differently than people without disabilities too. And this has had some really negative implications in policy. And now how to include people with disabilities and people with lived experience. I hope it's obvious that we are not interchangeable. It's really important to recruit broadly with not just condition diversity, but race, gender, gender identity, age, disability, and income diversity. It's important to be transparent about how a person's input and information will be used. It's important to manage expectations about how an individual may benefit as opposed to their participation helping the greater good. It's really important to use culturally competent and accessible materials so that you actually have informed consent and a real meeting of the minds. And finally, it is important to be respectful, and that sometimes includes offering compensation. Often the only person in the room who is not being paid is someone with lived experience, many of whom are living on fixed incomes. Thank you. I'm going to pass it over to Joanna.
All right. Hello, everyone. Today I'm going to talk to y'all about stigma and discrimination and how they contribute to pain and substance use disparities. I want to start by saying I have no conflicts of interest to disclose, and my views are my own. So now we can start defining some things. So stigma is a negative attitude or belief about a person or group based on a preconceived notion about that person or group. Stigmatization is acting on that stigma, so that's discrediting or invalidating that person or group. Discrimination is differential treatment of that person or group, and the only difference between stigmatization and discrimination is one falls within the purview of the law and the other one doesn't. And then, of course, intersectionality is the idea of wearing multiple hats, so having multiple stigmatizing characteristics can contribute to health disparities, which are just differences, and health inequities, which are unjust. And I'll go more into depth about these in my paper to the top right. Y'all should go and see it. So speaking of intersectionality, my lab and I published a paper back in February of 2022 looking at intersectional HIV and chronic pain stigma and its implications for mood, sleep, and pain severity. So on our x-axis, we have our groups that we created, the intersectional health-related stigma groups, and on the y-axis, we have our outcome variables. And so basically what we found was that people who were high on intersectional stigma experienced greater depressive symptoms, insomnia symptoms, and pain severity than those who were low on intersectional stigma. And there were also group differences in depressive symptoms and insomnia symptoms based on high and moderate groups. Then we broke down the two scales that we use, so the internalized stigma of chronic pain scales and the HIV stigma mechanism scale, to look at an indirect effect of stigma on pain severity. And what we found was that chronic pain stigma was related to depressive symptoms, which was then related to insomnia symptoms, and this was related to pain severity. And we found a similar relationship in people in HIV stigma alone. And then also keep in mind that this sample was 74% African American, mostly male, and 90% of the sample was below the poverty line. So this is another study that we did, another paper that we published back in February of 2021 from a comprehensive HIV and pain study. This is one of my other mentors, Shamika Cody, who specializes in substance use and abuse. And so basically we took people living with HIV with and without chronic pain and looked at their group differences in mental health and sleep. And basically what we found was that people living with HIV with chronic pain had greater insomnia symptoms and depressive symptoms than those without chronic pain. And then we broke down the groups even further to look at just people living with HIV with chronic pain alone. And we found that opioid use was associated with greater insomnia symptoms. So now I want to talk about some do's and don'ts. So do try to encourage your audience, be patient with them, understand that it's a process, try to lead by example, use supportive words, and try not to apply too much pressure, use non-inclusive language, ostracize the individual and or group, or tell them to be strong because they may imply that they are weak. And then I have, this is what a scientist looks like, because as scientists, we're not safe from the stereotypes and the prejudices that go on within our communities. I want to give acknowledgement to some people that are helping me get through my dissertation now, because it's all my dissertation work. So my lab to the far left, and then of course my wife to the right, and my two kids, Sheba and Genesis. I think I'll pass it to Emily now.
Thank you so much, Joanna. So yeah, I'm going to be diving into the experience of pain-related stigma in adolescents. So I don't have any financial disclosures, but I do want to acknowledge that I will be presenting research that has been funded by my K-23 award through NIAMS, and I will also be talking about some pilot work that was supported by the Goldfarb Pain and Palliative Medicine Fund. And a major contribution to stigma within young people with chronic pain is the lack of knowledge that it actually happens in young populations. Society tends to associate chronic pain with older adults. However, the prevalence of chronic pain in young folks are between 1 in every 4 to 5 child or adolescent might have a chronic pain condition. Headache tends to be the most prevalent, and rates are on the rise. And this was already touched upon in the previous presenters, but pain and the chronic pain is largely invisible. We can't detect using objective clinical ratings. We can't measure it through imaging or blood tests. And so a lot of providers, family members, and other people within the lives of these young folks with chronic pain have to rely on their report. And that increases the subjectivity of that interaction and therefore the vulnerability of not feeling believed and stigmatized within that. And so we conducted focus groups to truly understand what the experience of pain-related stigma was like in this population. And here are some of the characteristics of it. There's a lot of pain dismissal that occurred, largely due to the diagnostic uncertainty within this population. Doctors just saying there's nothing wrong with you because of those negative medical evaluations. Others feeling that they were actually making it up or exaggerating it to get out of something. So this example is within the school setting. Sit down, you need to get back to class, stop faking it. And then another characteristic of it just all being a mental health condition. It's because of anxiety, depression. You just have to see a psychiatrist, which undermines the biopsychosocial evaluation and treatment that we know is the best to help individuals with chronic pain. And so these are important features of how one may experience chronic pain as a young person. Myself and the group of researchers I'm working with developed a pain-related stigma scale to try to understand how pervasive is this. I heard it a lot clinically as a pediatric psychologist working with young people with chronic pain, but I just didn't know how often this was coming up. So we surveyed using this pain-related stigma measure, adolescents with juvenile idiopathic arthritis. This group was a comparison group that tended to have better diagnostic features. So I was curious to compare that to those with chronic pain conditions that were a little bit more ambiguous and hard to diagnose. So those with chronic localized musculoskeletal pain and juvenile fibromyalgia. And you can see across all three groups, the majority of my sample reported rates of pain-related stigma compared to those who did not report any. I thought it was important to highlight the experiences of stigma in medical providers. As researchers, especially if we're interested in enrolling participants, young people with chronic pain, we tend to do that in hospital settings, medical settings. And so it's important to know within these settings is there stigma that is being experienced. And as we see for JIA, where there's perhaps greater diagnostic clarity, there's less pain-related experiences from medical providers. But as you had more diagnostic difficulties or clarity, you can see the increases in pain-related stigma across the other two chronic pain groups. And this can impact recruitment. So on my next slide, I'm going to share the feedback of a parent of an adolescent with chronic pain that we try to recruit just for our pain-related stigma study that highlights some of the challenges that this might present in research recruitment. So in an email, a parent wrote, "What will my child benefit from? Something for years she was told that's all in her head. She no longer trusts doctors due to them dismissing her. Until you feel her pain and other kids with her type of pain, you'll never understand. A stupid gift card is even more lousy. Don't reach out to me again. You can say PT and therapy will help, but it doesn't." Again, we're lost in understanding juvenile fibromyalgia that we renamed to chronic pain syndrome. You have all these doctors that have all these degrees, but without personal experience, you lack understanding. And yes, my ego needed to heal a little bit after reading this, and at the same time, really highlight that families and especially youth with chronic pain are on this journey. And it's very challenging when they feel stigma and lack of diagnostic clarity. And we have to appreciate that as researchers trying to support these populations. So what are next steps? I think it's important that we increase the awareness that pain-related stigma exists, and it might actually influence our health outcomes or the outcomes that we're interested in researching, but then also our recruitment efforts. And as the presenters have already shared, having patient and parent advocates can be very helpful, even from the very beginning. The study design and what are we using in our recruitment scripts can be very important because language is really important. We We have to make sure that we're doing person-first language. We're reinforcing that biopsychosocial model, and we're not unintentionally reinforcing that it's either all biomedical or all psychosocial. And especially in our young populations, the use of metaphors to describe what chronic pain is can be very important. And I want to highlight one resource on my next slide that is in those resources that was in the link that was provided. And this is something that Dr. Rachel Coakley and Neil Schechter out of Boston put together on just the use of metaphors to not only describe what chronic pain is, but then also how treatment can be helpful. Because even as you're trying to recruit, if they're still confused about what the chronic pain diagnosis is, and they need some support with wrapping their head around why participating in your research can be helpful, not only can those patient advocates can be really important, but making sure that you have a way to describe it, and the use of metaphors that are presented in this paper, I find might be very helpful. So my next slide has my references, has my contact information. I'm really looking forward to talking more during the discussion about this. So thank you so much. I'm going to hand it over to Dr. Imagery Sill to talk about her work with pediatric sickle cell disease.
Thanks so much, Emily. I'm happy to continue on the discussion about pediatric pain as it relates to sickle cell disease, specifically community engagement and cultural adaptation of pain interventions. So for those who are less familiar with sickle cell disease, it is the most common genetic blood disorder that has the highest prevalence among individuals of African ancestry. And in the United States, about 1 in 500 Black Americans have sickle cell disease. And pain is really the hallmark feature of sickle cell disease. It occurs across the lifespan. Often pain increases as children get older, and we see the emergence of chronic pain in adolescence, and that can continue into adulthood. And unfortunately, racial bias and disease-related stigma continues to be very prevalent in sickle cell disease. We know that there still remains a lot of provider bias related to sickle cell and the use of stigmatizing language that can really lead to an underassessment and undertreatment of pain in sickle cell. And there's well-documented literature to support the fact that there is a lot of direct and indirect consequences of stigma on the social, psychological, and physiological aspects of health. And collectively, a lot of this bias and disease-related stigma can relate to the inequity of resources that are available to individuals with sickle cell disease at the institutional and systemic level. I'd also like to draw your attention to this image on the left here, which is a painting by Hertz Nazaire, who was a Haitian artist living with sickle cell disease himself. And he was well known internationally for his art and paintings where he really illustrated the lived experience of pain related to sickle cell disease. And he used his art as a way to advocate and raise awareness of sickle cell. And the community was really deeply saddened by his loss a couple of years ago when he died at the young age of 48. You'll see a few more of his images in the next couple slides. Even to this day, there still remains a lot of stigmatizing language that is prevalent in research as it relates to sickle cell. You'll find a lot of peer-reviewed publications that includes these kinds of stigmatizing language describing individuals with sickle cell disease as patients who are difficult, who are hard to reach or non-adherent, or they come from very chaotic family backgrounds, or mistrust doctors and research. And oftentimes when this stigmatizing language is present in research, it is used as a way to help explain away some of the limitations of research study designs, and inevitably ends up placing the blame on the individual with sickle cell disease. And it is really imperative on us to be able to shift and challenge those assumptions and narratives to not what participants need to be doing differently, but what we as researchers need to be doing differently to engage and support them better. From some of our work with some of our patient advisors, they've shared their experiences of stigma and bias. One 12-year-old male stating, "My teacher thinks I'm faking it and doesn't let me go to the nurse." Another teen saying, "It's like the providers ask me how bad my pain is, and maybe because I'm playing video games and not screaming or acting crazy, they don't believe I'm hurting." And there are definitely those people that think I'm just coming to get drugs. Another teen mentioned the invisibility of both chronic pain and sickle cell disease, stating that people can't see it, and so they don't believe them when they're hurting. So through the lens of an anti-racism research framework, it's important for us to begin to consider how we can begin to reframe our study designs to better meet the needs of underrepresented groups. And oftentimes individuals with sickle cell and their families really want to participate in research, but they're not aware of the options, again, because of bias that may be limiting their access or that it's not disseminated in areas where they typically seek information. And so it's imperative on us to begin to build better engagement with our community partners in order to extend the reach and impact that our research can make. So was described earlier, community engagement is an important piece of this, and it really exists across a continuum as depicted in this illustration. You can see that community engagement really can be evident in a lot of different ways where involvement, impact, trust, and communication increases along the spectrum. And it's important to realize that we don't always have to start at the highest level of shared leadership, but starting somewhere along this pathway can be an important step moving forward. We often use community engagement to help inform our cultural adaptation of interventions related to pain. And we do this primarily by designing and adapting interventions while keeping implementation in mind. And this often includes including our patient and family advisors early on in the process and doing formative and participatory research methods to understand their lived experience and what needs to be adjusted or changed in order to help address some of the concerns that they may be sharing, and to also infuse their language and their words into creating a treatment program that will be relevant and meaningful for them. It also is helpful to focus on reach from the beginning. So really thinking about, who is recruiting and how and where we are recruiting. Taking an equity lens, so considering the fact that a one-size-fits-all approach may not be appropriate for everyone, and we might need to think more flexibly and consider more adaptive types of interventions to meet the needs of our underrepresented groups in pain research. And collectively, these strategies can help narrow pain inequities by increasing satisfaction, effectiveness, and sustainability of treatments over time. Just a brief thank you so much for your time and attention. And anyone is welcome to reach out to me directly. And then I'm happy to pass it along to Dr. Kavanaugh.
All right, terrific. Thank you so much. Appreciate this. I'm going to try to keep it moving so that we can get to our discussion. I have the privilege of recapping what has been shared by the other investigators and faculty, as well as maybe give some ideas about how together and individually in your own settings we might take some action steps. Okay, I have no disclosures to report. Yep. And then just to summarize that stigma and stigmatizing experiences really are profuse. They're at multiple levels. We've heard all about it in the past, almost hour now. And I'm going to focus a little bit more on the lens of how stigma can be a barrier both to care, but really to participation in research. Although I will use some examples from clinical care and healthcare practices that we can keep in mind as we're thinking about our research activities. And really, we can address this. This is something we can address through programmatic priorities. And I would advocate, I'm going to start off with a big one, to understand stigma broadly and in our local environments, and then implementing specific dedicated strategies in training our procedures and our policies. So I had the privilege at Vanderbilt of working with really amazing experts in community engagement overall, and Consuelo Wilkins in particular. She led recently a team to expand our measurement of research trustworthiness. And so while we talk about these things, we all know here we're in the business of measurement, and past measurement of research trustworthiness scales had not been developed involving the target populations and the people that mattered most, and their voices were not integrated. And I just put on the left there that really what we're trying to get a tackle on is organizational trust and in specific research trust. And this is the scale that I'm going to give you a little bit more information about, recently published just last month, available for use, and really covers trust and distrust. Mistrust is another concept, not enough time to go over today, but to know that these are interrelated and have some overlap, but are distinct constructs. Moving on to the survey itself, this is an 18-item survey, and these are some examples of the items that are available. And I would advocate that you consider deploying this, measuring this in your environments to try to better understand people's thoughts about your organization's trustworthiness. They mentioned things in the trust domain. These examples in particular, when they did their validation study, were ones that were different among different minoritized populations, both race and ethnicity, really focusing on whether or not medical researchers are telling people everything they need to know, whether they're giving someone something that might hurt them, whether there are benefits to society overall, etc. In the distrust area, really the concept of secrecy and things that are secret, non-transparent, and using those words, as well as untruthfulness, that researchers may overtly lie to convince people to be them in a study. And I think advance the slide, it might bring up a animation there. And so again, the why I want to really advocate for this particular measure is not just that it was developed by my colleagues, but that really it is was developed with intent to examine research programmatically and involve people that experienced again, stigma in different ways. There was buy-in from leadership, and you must be thinking about engaging your leaders and integrating this into a strategic plan overall around research operations. Okay, so we heard a number of the other speakers earlier spoke a lot about belief and validation and belief. And a big part of this, and research included, as we're inviting people to participate in studies, is acknowledgement of their lived experience and avoiding disbelief, discounting, lack of understanding, and that judgment. It is important to engage in dialogue about what matters most and acknowledge those beliefs and experiences that lead to feelings of disbelief. And I show you here actually our flyer that I'm part of the HOPE trial, which is a HEAL supported trial that's examining chronic pain among people living with end-stage kidney disease treated with hemodialysis. And I want to show you here, and I think if you click again, it might bring up my animation, that this was developed in a partnership with our patient advisors. And it was very important to them that on our flyer, front and center, was the call out that have you felt that your pain was ignored by others, in particular the healthcare system. And so that was one of the aspects that our advisors really felt was just important to call out. Next slide. Yep. I just want to say our website's up there. We have a video. The video has only patients telling their stories directly as part of the recruitment process. And again, just really making good on engaging patient advisors fully in your research really can transform it. I will say the study overall met our recruitment goals earlier. People living with end-stage kidney disease and dialysis are notoriously very difficult to recruit into clinical trials for a variety of reasons. But I think because of these practices, working with the advisors really led to the success in this particular trial to date. Language matters. We've heard this a number of times again already today. I want to present to you some words, stigmatizing words that will give you examples. These are pulled from medical records. So these are words that healthcare professionals are writing in the medical chart. Extra important for all of us that are medical professionals nowadays with open notes. All of our clinical notes really are intended to be available for viewing and consumption and use by all patients. It is important to know and avoid and not use words and phrases that indicate disbelief. And there's some examples here, and again, some words that could be reviewed later. And it's important that we do training. And so think about training, again, this happens a lot in healthcare professionals, but also in research. How are we training our new coordinators? How are we training our project managers, our investigators? What are we doing and how are we integrating health communication, these practices into our training? Onboarding, ongoing training. And there are programs that can help do that, both to instill skills and practices for listening and empathy, as well as, again, different ways that we can do this that can both impart the skills as well as maintain the skills. And this can include role playing. We can have simulations. I think AI will be coming down the pike in the future. And I just want to emphasize also that it's not just what we say and what we write on the page, but also nonverbal communication or interactions are really important. If you advance the slide, please. Yep, things like eye contact, where we position ourselves relative to other people. All these things are very important with engaging people. Again, and building that relationship of trustworthiness. And I just want to mention some operational considerations. Again, this is relationship building that we're doing, equally important in research. If you're able to develop teams and ways that you're doing the research, especially for multiple visits over time, where you can have continuity between the participant and the research staff, that is advantageous to support this, as well as understanding what time is required for each of those interactions. And then we shouldn't have to say it, but we'll say it again, the setting and ensuring that there is evidence of privacy for whatever it is that you're doing, specifically when you're talking about sensitive materials. Okay, so in summary, think about assessing trust in your research as an organization, perhaps the community as well. Use validation of the experience of chronic pain, emphasizing interactions, both verbal and nonverbal, that convey belief. Also think about how you can purposefully integrate this into your training curriculums, individual and perhaps organizational levels, with a focus on language, listening, empathy, and again, structuring protocols and procedures to be attentive to the factors that really build those relationships, indicate belief, eliminate, and ultimately with the goal of eliminating stigma. So thank you. One last call out, and I'll just ask you all to be thinking about what action you will take in your local organization. So thank you for the opportunity. I'll hand it back to Dr. Gooden.
So I've already seen a few questions popping up there in the chat. I think we've now gone through our panel presentations. So we'll be moving into the Q&A portion of this. So I think on the one hand, there's some stuff to be addressed already. Also, and this may generate some questions and answers, it may not. This is sort of my little slide contribution, which will maybe drive home some of what's been talked about in terms of where some of the pain stigma may manifest, given its sort of invisible nature, or how a person's experience of pain doesn't necessarily always correspond to what a healthcare provider or anybody else for that matter might expect to see as a reason for the pain. Let me just show you something here real fast. What you're looking at is two patients, okay? Patient one, patient two. This is an MRI of their spine, so basically the low back, right? And if you go down, you can see right there in the middle on patient one, there's the vertebra and the discs between them. And as you go down, you'll see a dark spot right there in that canal, which is basically a disc protrusion into the nerve space, impinging nerve. Okay, so that's some pathology there, if you will. Patient two, if you look and you go down, you don't see any of that, right? So for all intents and purposes, it might be described as healthy or a sort of non-pathological back, if you will. My question then is, which one of these patients is experiencing chronic low back pain? I suspect the folks are going to get this because they've been paying good attention. Well, look at complaining. Smart people. You smart people. Yes, it was a bit of a loaded question, a trick question of sorts. These are both individuals with chronic low back pain, right? And not to belabor the point that's already been made, but when we start talking about like this idea of medically unexplained pain or non-specific pain, there's actually been some research showing pretty well that the more medically unexplained your pain is, or the more sort of unattributable it is to a defined reason that I can see on an image, the more likely it is that you're going to be discredited or avoided or actually just disliked. And you can see those studies that were published down at the bottom of the slide. That was actually done by a group out of the Ghent University in Belgium. So this idea of pain stigma isn't just an American one. It appears that these issues are popping up for people with chronic pain around the world. Last but not least, this idea of like sort of imagery and thinking about what a person with chronic pain might look like. If we were to have a pamphlet recruiting for a study or what have you, we might expect to see an image like the one on the left, right? Okay, that's somebody with chronic low back pain. But the fact is that in the same day, the same person may also be represented by the image on the right? Because people with chronic low back pain actually have good days, right? But just because you see an image of that person on the right, that doesn't mean that their chronic low back pain is any less salient, right? Or that it's not diagnosable as such, right? The point being is that this individual is somebody who is struggling with chronic low back pain, but sometimes an image or an experience of somebody like you see on the right sort of invalidates their experience on the left. So just to point that out there, right? It's a complex phenomenon, chronic pain is, right? So let's stop with that.
We have a really good juicy question in here to start it out about addressing stigma surrounding opioid use in treating chronic pain, either with language or actions on behalf of healthcare providers or patients. I think, that's a tough question. Burl, answer it.
Like Kate's got some response, which is awesome because Kate always has great responses.
Well, I don't know. I mean, one of the things that's really hard, I think, is that stigma, from my understanding, is sticky. It's really hard to remove once it attaches. And with someone who is using opioids for chronic pain, they're dealing with bootstrapping stigmas, right? You've got the stigma associated with pain, and then you've got the stigma associated with opioids. And the narratives, sort of around what's happened with the overdose crisis that sort of maybe even blame people with chronic pain, because they don't understand. If these people just bore up with their pain like everybody else, then people's kids wouldn't be dying on the streets. I mean, I think there is a real attitude that, that use is problematic or always problematic. I think, the ways to mitigate it are manyfold. I mean, we've got to work on changing the narrative around this. Because there is, I think, a perception in the media by even providers and researchers that nobody with non-cancer pain should ever take opioids for pain, and yet that is not what even the guidelines say. Guidelines say that it's not good for as a first or second choice, but that in pain that isn't well managed by other means, it may be appropriate. I used opioids to manage pain for many years when I couldn't stand or walk. I was fortunate enough to have a series of surgeries that changed that, and I don't require them anymore. But I think, there's training that needs to happen around that. There is law and policy change that needs to happen. We just got a law passed in Colorado that sort of protects providers to try and avoid some of the forced tapering and dismissal and discrimination in care that's happening to people because of this, people who were placed on opioids, by the healthcare system, many of them for many years. And now national studies show, providers are not, particularly primary care providers, are not even willing to treat them. So I think it has to be multifactorial, but I also think it's really tough because the narratives are very dominant and the stigma is very real. But I'd love to hear other people's thoughts.
I can pitch in too. So I have a lot of answers to this question because I like the question, but I think I want to focus on, like, at the individual level, what can we do? Because the individual is the one that matters. So I think we can start with resilience training. So resilience training is basically just like helping that person understand that all the weight is not at the foot of them. It's at the weight of the system as well, at the foot of the system as well. And then also letting individuals know that they have resources to take care of their pain, their opioid needs, and then also their mental health, because that's where a lot of this stems from. And then letting them know that it's okay to speak up. So going out into the communities, educating them as well, letting them know that like we're aware of this problem and we are here to help you. That will help them to be more comfortable to speak up, and that'll help us to help them, if that makes sense. And then also at the systematic level, like she was speaking about, like Kate was speaking about, we can do some implicit and explicit bias trainings for like healthcare providers, just to make sure that they understand what's happening. Because a lot of times, pain is just not something that's taught in the medical system. And so having something like a pain class or something like that to help people, help educate people better on like what this even is, what does it look like, and how it is different for different people.
All right, very good. In an effort to make sure that we're addressing all questions as they kind of come through the pipeline, what have you, I want to point one out that was just brought up in the chat by attendee Jennifer Cummings. And it just says, I'm wondering if anyone could comment on the nuances of using inclusive language in neuroscience research. Specifically, it feels complicated to frame brain-related research without contributing to the "it's all in your head" narrative, which I think is a lovely question. And I'd actually like to comment on that real quick, right? As somebody who sort of dabbles in the neuroscience space as well, the "it's all in your head" can actually be pejorative or empowering, in my opinion, depending upon how you spin it, right? Like that idea of like, well, I don't know, like take the image I just showed you all a minute ago. Well, I don't know, that image suggests there's no good reason for your back pain. You need to go see the psychologist, right? That is likely going to be a more of a pejorative type of the pain's all in your head type of framing there, if you will, right? However, if it is presented to an individual that pain is a subjective experience, right? And it's going to be colored by how you live your life and what is sort of perpetrated against you, or the things that you engage in behaviorally, right? Such that how your brain makes sense out of your pain does somewhat mean it's in your head. But again, in your head doesn't imply, it doesn't mean to sort of say like somehow that's made up or it's disproportionate to what it should be or what have you. In your head means that it's uniquely your experience. So let's talk about that and use that to better understand what we could do for you. And in that regard, it's a bit more of an empowering twist to let the person know that, like, much like if you had diabetes, or much like if you had cardiovascular disease, there's some self-management that needs to go into taking care of your chronic pain, right? So as a provider, I want to help equip you with tools, but ultimately those tools are going to be yours to use, but they need to be unique to your situation. So again, that pain is in your head type of phenomenon doesn't have to be pejorative.
I would also just add that, when you can break it down on a neurological level, that brings it to kind of a biomedical, psychosocial connection. There's a lot of empowerment, because I think this all in your head indication is that it's stress-based and it's out of your body. It's all within your control, right? So I think you have a unique opportunity to share that in the interconnectedness of what our brain, like how our neuroscience is all connected within the pain spheres. And I think that then brings it into a more real level for folks if they're able to validate, well, my brain is processing it in a way that is outside of my control at times, but there's elements that I can do to also support how I can navigate it using the information that I know the way it's processed in my brain too. So similar to like what Burl was saying, is that it can be empowering, but I think the more that we can throw knowledge and how all these things are connected, the more the person can feel validated, especially when it brings it to some type of biological level of what is going on as well. So education can be very powerful and validating.
I think there's a really interesting question about journaling as self-advocacy and the role of folks with lived experience with pain, keeping journals and using that as a way to communicate. I don't know if any of our physician researchers have worked with patient diaries before, if you want to speak to that.
This is Carrie. I'll jump in. I think that is a great idea. In various complex chronic conditions, narratives and journaling, I think, has been studied and can be impactful. That being said, in healthcare usual practice, in terms of it being integrated purposefully into workflow, maybe more of a challenge there. I don't know of it being more having as much penetration, but maybe in certain contexts. It allows clearly the patient voice to be clearly and authentically represented. The receiving, who's that being shared, like, so whether they're leaving it, just for themselves, or if they're sharing that information with the practitioner, I think that, or the researcher, for example, that's where things like the training of the team, I think, becomes of utmost importance to be prepared for how that information is handled and used to support the patient, either in their clinical care or in their involvement in the research.
Yeah. I think it's also useful in a clinical and research context because, again, given the subjectivity of a person's experience, we may see them in a clinic setting or in a research setting for, like, say, an hour, and that's really just a snapshot in time where we try to then generalize from what we learned in that 60 minutes to what happens for that individual in a week or a month or a year. But when you actually have a journal or multiple data points, if you will, it can also be enlightening to see patterns and to what extent certain patterns may correlate with things that can sort of mitigate pain or epilepsy symptoms or exacerbate them. And some of those triggers or buffers, if you will, can be actionable, right? So that may spur a new research question, or it may help an individual to sort of understand the ebbs and flows of the phenomenon that is pain, or in the case of I just saw who mentioned that, Chelsea, like epilepsy, right? And then hopefully see, like, okay, maybe there's something that I can work on here and share with my healthcare provider as a team to generate ideas for management. Yeah, and I mean, that doesn't necessarily preclude stigma per se, but in my mind, I like it because it can actually help provide education or greater context. And let me just say, from a stigma standpoint, I learned a lot about this as it related to HIV stigma. At least in the healthcare system, a lot of that stigma isn't maliciously perpetrated. Like, people don't wake up and they're like, I'm going to make all my patients feel like crap today, right? It's sort of unintended, and these are like these sort of subconscious biases where when people are educated and those things are brought to the forefront, they're like, oh, I didn't realize that. And that education and context can actually help providers be more aware and then change behaviors accordingly.
Thanks, Burl. We also have more of a comment than a question, but there's a discussion we have going on with Keith Schulman in the chat about the CDC guidelines. Before the CDC guidelines, he writes, providers were caught between a rock and a hard place, prescribing opioids and balancing addiction issues. Now patients are the ones who are stuck as providers dismiss them. Burl, I know you answered in the chat, but if I'm curious if folks want to comment on those CDC guidelines.
Yeah, please do. My answer wasn't great, so anybody who has a little bit more context to that would be awesome. And not to call out Kate Nicholson, but she has amazing thoughts on this topic. So maybe I just call out Kate Nicholson.
Okay, so yeah, I mean, patients certainly have, there are lots of studies showing discrimination and forced tapering that can actually endanger people's health and care. I do think there was an uptick, which the CDC has recognized after the 2016 guidelines came out, because there were a couple of very concrete provisions, one regarding dosing and another regarding the number of days a medication should be prescribed for acute pain, that were just lifted by policymakers across the sphere, healthcare systems, pharmacy benefit plans, medical boards, pretty much everyone, and handled in a one-size-fits-all way. And I think somebody else mentioned how dangerous that is for stigma, for disadvantaged populations of any sort, any kind of one-size-fits-all approach. But that is that is definitely something that occurred. I actually met with the CDC in 2019 to see if they could clarify that that's not what their guideline was saying, and that patients were being harmed. And they actually came out with a public-facing clarification. I was also on the CDC's work group for the 2022, just to be in full disclosure. And they have removed those sorts of thresholds from the mainline recommendations, again, acknowledging harms. The problem is, as I mentioned initially, stigmas and biases and discrimination tend to adhere. They're really, once they've happened, it's very complicated and complex to sort of undo some of those harms.
And just to speak on that a little bit more, that sort of analogy or the metaphor of like a pendulum, right? So around 2000, the pendulum was such that nobody was between a rock and a hard place, right? Because there was a lot of opioids flying around. And again, some of that was well-intended and some of that was not so well-intended, because there was also a lot of money flying around. And then once it became apparent that, okay, there's some real issues going down here, that pendulum started to swing back in the opposite direction of way more restriction, taperings, and then the rock and the hard place became the patients, as it relates to the healthcare providers, because the healthcare providers were rocking a hard place as it related to like the DEA and law, right? Or misinterpretations of law, because guidelines aren't law as far as I know, but they were sort of interpreted as such. The point being is that, like, if the goal is sort of a well-intended balance, then the pendulum swinging never really achieves that, right? Because the nature of a pendulum is pulling. You're either here or you're here, but you need to be here. And I think there's a lot of folks who would like to sort of see it here, but you have people at each end of that pole, provider, patient, or otherwise, who are like, no, we need a very restrictive sort of prescribing, versus people being like, no, we need it to be very judicious, I guess, for lack of a better word. So anyways, I don't know exactly what the answer is, but I do think that a lot of chronic pain stigma is inherently steeped in opioid stigma, because the question that always is sort of lingering is like, is this person trying to get some opioids?
Sumitra, you've got your hand up.
Yeah, thanks. I was also, going to share kind of the power of advocacy as well. As it relates to the CDC guidelines, it also had a really big impact on the sickle cell disease population, in which opioids are a very common form of treatment for pain. And this really, impacted the quality of care that they were receiving in emergency, rooms and primary care. And just by way of brief example, how the sickle cell medical community and, patient and caregiver and adult community really pulled together to be able to advocate for sickle cell and advocate for changes in the CDC guidelines in order to be responsive for the needs of this specific group. So we are a strong collective voice as pain researchers and clinicians. And so I just don't want that to get overlooked, that there's a lot of power in our voices too, as we work towards advocating together for the individuals we're trying to help and support.
Kate, last word on this topic before we go to our last question.
Yeah, I do think the advocacy is super important. Of course, I still hear from patients every day who are losing access to care. We have people in our group with sickle cell who are facing barriers still. So part of it is just sort of the lasting repercussions, even if advocacy works, even if agencies are responsive, even if we get laws changed, it takes a really long time, just as it does from take time for a study to trickle into practice. It takes a really long time for laws and policy changes to actually impact the lives of people. And I just wanted to put a bigger lens on this, so it's not just about pain and opioids, because, it was interesting that Burl mentioned working with people with HIV, and I did that early in my career as a civil rights attorney, and we ended up having to basically win the right to routine health care for this, in this case, dental care, all the way in the US Supreme Court. in the 90s. And I think in these public health crises, because there's so much narrative, because there's so much attention, because there are all these policy responses, sometimes what ends up happening is that we end up stigmatizing the people who were intending to benefit, and that has lasting implications in their ability to get access to care. So it's not just about pain, it's not just about opioids, it really is, sort of a bigger picture problem with how we handle public health crises for vulnerable populations.
Thanks, Kate. And a last question, comment, things to talk about is study design and how do we improve study design, specifically around good days and bad days. And Burl, do you want to speak to your answer?
Our pain measures, whether it's in the research or in the clinic, often ask about like your pain right now, if you're in the clinic, and that's like 0 to 10, or our like research context, maybe like, what was your average pain? What was your worst pain? But for a lot of folks, their experience of pain on any given, day, week, or year fluctuates, right? So designing studies to sort of understand that, again, speaks more to a person's lived experience. And depending upon the pain condition, a person may wake up in the morning and feel like, okay, I can accomplish some things. But over the course of the day, as they go about their daily routine, they need some pain relief or something by the end of the day because it's become excruciating. Or in certain sort of osteoarthritic and rheumatologic conditions, it can actually be the exact opposite. They wake up in excruciating pain, and once they're able to get going, then the pain abates a little bit. So sort of understanding the pain phenomenon, there's some interesting research coming out showing that there's sort of a circadian rhythmicity to pain and pain sensitivity, diurnal rhythms, such that it can vary across the day. So understanding that, I think can be useful, again, for the lived experience of it. From a clinic standpoint, it can help people to sort of plan out their day. When might they be at their best versus not so much? And then in the research, again, providing more useful granularity to that lived experience can enhance understanding and may be very useful for intervention development, so forth and so on.
Yeah, I agree with what Burl's saying, is that pain is influenced by so many things. And I think what's really going to be powerful in reducing stigma is that good days doesn't equal they don't have a pain condition. And that's where a lot of the individuals who live experience get frustrated, is that, oh, all of a sudden, I've had a lot of even school nurse conversations on the phone of like, well, I saw them laughing in like the lunchroom, so they must not have pain, right? And that's the problem, that I think we like label those moments as all of a sudden the pain is gone, they don't have the problem anymore, or they're faking it, or it's an indication that nothing's wrong. And I think what's important in our first, we should definitely measure the variability of pain and what is influenced by it to try to promote things that are going to alleviate the pain, right? And that can be multifactorial, but I think it's in our interpretation of what that means, and we have to be mindful of potential unintended stigmatizing beliefs that might unfortunately discredit the population more instead of just appreciating the complexity of it. And so that's what I would kind of add on to that piece of it. And why patient advocates are important in helping even with the interpretation of what we're doing and our research findings.
Thank you so much, Emily. And thank you everyone for so many engaged questions. I think we got to everyone's question. If we didn't, I'll tell you how you can get it answered later. But before we do so, we have a couple big favors for everyone in the audience. We really appreciate you attending today, and we would really love to do sessions like this again in the future. We just want to do a real quick poll right now. A poll will launch, and we want to know what your ideas are. We want to hear how you would rank these different ideas we have for what a future session might offer. So if you could just please rank these in the order of your preference. And you know what, if you didn't see an idea there and you have an idea for similar sessions in the future, go ahead and put it in the chat as well. We'll be looking at the chat in addition to the results from this polling question.
And then for everybody who was just hitting the chat saying, great presentation, thank you so much, I would just like to say our pleasure. As part of the Heal Connections initiative, the HEAL initiative, which funds HEAL Connections, and the HEAL Connections mission for research, dissemination, and implementation. Things like this are what we want to be doing. We hope to be doing more of them. So stay tuned for additional programming. We'll be soliciting, a la the poll, what our audience wants to see, but then also some additional things that we feel important to offer. And we'll be hitting our listservs with emails for future programming. So hopefully y'all will tune in.
So the answers to the poll are all of it. You want all of it. We have a lot of great ideas. Clara, you are speaking my love language there as a community volunteer DJ. I also have been thinking about music-based interventions for pain. I think that would be great. So it sounds like you guys are up for coming again. That would be fantastic. Let me tell you a little bit about our office hours. Like I said, if we didn't answer a question you had today, or you'd just like to keep the question going, we're going to be having a combined office hours on inclusive language imagery and storytelling for both addiction and pain research teams. So we heard here today, there's some interesting tensions and overlap and things to learn for all researchers. And we will be doing that, as you can see, on September 18th, noon to 1 Eastern time. We'll be sending this link out so you can register right after this session with all materials. So you'll have more information on how to join this, and we would absolutely encourage you to do so. Then finally, if we could ask you one more favor, let us know how we did. We're going to give you a link to our evaluation survey. We're going to hang out for a couple more minutes. We're going to put the music on. We'll be reading the chat. If you could just take the last couple minutes of this hour to let us know how we did in the eval. If you have any other questions or comments, you can also put them in the chat. We will hang out and play some music and just keep the conversation going for another couple minutes. Thank you so much to our presenters, to Burl, and to all of you for attending and caring about this really important issue. We look forward to future collaboration.